distal proximal and see these structures stay in the center of the screen before they start going off their various directions. So we're going to focus on the medial malleolus first and then work our way posteriorly out into these soft tissues. So this is the tibialis posterior, also called the posterior tibialis tendon. In all the references, you'll see it called the PTT. So that is the posterior tibialis tendon. Bordering it in parallel at the malleolar level is the flexor digitorum longus. It has a longest way to go. It does actually traverse this canal under here, some soft tissue landmarks that we'll talk about called the knot of Henry before it takes its immediate turn out to the digits in the bottom of the foot. But it does run in parallel to the posterior tibialis tendon at the malleolar level, and then from there it's easy to trace. It does have a more distal musculotendinous junction than the posterior tibialis tendon, so that's also helpful. And then its neighbor, just immediately posterior and relatively parallel at the malleolar level, is the flexor hallucis longus tendon. And as I mentioned before, anything with the word hallucis means big toe. So this is the flexor for the big toe. And it does have the most distal musculotendinous junction. And if you're dealing with an athlete or a runner, don't be surprised if you see that muscle coming all the way down into that tarsal tunnel area, causing some issues. Some overdevelopment might cause crowding, tenosynovitis, swelling, ganglions may also cause crowding in this area. And so you can end up with some FHL tendon sheath issues as it has its own tunnel here, and we'll show that on one of the slides. But flexor hallucis longus is this guy here, also called, and I didn't put this in the slide and I should, but a way to remember this from medial or malleolar level and posterior would be Tom, Dick, and Harry. So that's one way people remember this. Not a subject of today. It's just something else that your transducer is going to lay across. So if your probe is over here at the malleolar level and you're slicing the ankle transversely, there are our subjects here on the left side of your screen typically, but the right side of your image is just going to be all this wavy soft tissue stuff, and that's typically Kager's fat pad, and then you might see an anisotropic oval on the far side of your screen, and that's the Achilles tendon. So just be aware of that. It's not the focus of today, but it will be in the image. So here we have that slice that I mentioned, starting at the malleolar level. So medial malleolus, we see the posterior tibialis tendon, flexor digitorum longus, and then we're not going to focus on these other guys. They're not a part of the tendons, but here is the musculotendinous portion of your flexor hallucis longus right here. We're going to work our way to long axis of each of these structures, and you can see the reference of that same axial slice or that same transverse slice down here. Notice the angle the transducer should go. I don't want you to go 90 degrees to the skin here. I want you to lean the probe. I want you to lean the probe handle towards the Achilles, and that will allow you this nice bony backboard of reference. If you only take a 90-degree slice here, even though it looks like you're going to have a nice bony reference, because of the shape of the tibia, you're only going to catch part of the malleolus, and the rest of the tendon will be floating out in soft tissues. So it's not much of a reference point of the bony acoustic landmarks in the area. If you just take a 90-degree slice from the skin down to the malleolus, I want you to lean the transducer more towards the Achilles and then fall off the malleolus posteriorly. And I'll elaborate that on the live scan, but here's our relative transducer angle. Here's the tendon that we were talking about. Deep to that, after this this tendon jumps off the malleolus, this is part of that deltoid ligament complex. Now you're familiar with those soft tissues. It's not a mystery anymore of what we're seeing down here. And sometimes those layers are degenerated and have a more laminar look, and now you know you can move the ankle around and kind of see the differences between those and if they're an issue or not. But I have seen ligament old degeneration look like some sort of synovitis because it was anisotropic in some cases and not anisotropic in other slices, and it looked like some proliferative synovitis coming out of the tibio-talar joint. But what it really most likely is the degenerated ligament layers making things look like they're coming from the joint. All right, so distal to the malleolus, now we're traversing towards the insertion. The neck of the talus is a great landmark to follow this, but here's your tibialis posterior tendon, and the shadow of the navicular is out here. But the dynamic maneuver is the way to go. If all this looks ambiguous on the patient that you're scanning, not our patient today, it'll be very easy to see. But the patient you're scanning, if all these tissues are blending together because they have a very degenerative ankle and the tissues just don't look right, then we're using ultrasound. So we're going to make it move, and I want you to do inversion of the foot and make that navicular move. So we'll do this in the live study, but you can see how the navicular pulls the posterior tibialis tendon here, and it's very fan-shaped. And it has a very anisotropic deep tissue characteristic here because a lot of these fibers hammock underneath the navicular, much like the spring ligament would as well. So they fan shape around the navicular. I've heard it described as a snake eating an egg at this point right here, where you can see all these fan-shaped fibers. But make the tissues move, and that'll be the best way to get around these tendons. Next, immediately posterior to that, so go back up to your posterior tibialis tendon and then just translate the transducer exactly in parallel fashion posteriorly, and you'll catch the flexor digitorum longus, and then just wiggle the rest of the digits, the toes, the smaller toes, to make this tendon isolate itself. Medial malleolus, talus is coming into the view. Let's go distally and see what happens after the medial malleolar level, because that's when I said all these tendons go their different directions. Again, wiggle the little toes, and we'll do that in a live study. But what looks like a bunch of weird synovitis and junk out here is really just those transverse views of the deltoid ligament complex. And we don't want to call any of this fluid or any ratty tissue disruption until we dynamically take a look at the deltoids. Even more posterior in the same parallel fashion. So you can see now we're wrapping our transducer more posterior in the ankle in this axial slice, and you can see how far back we're going. We're leaning the transducer very much against the Achilles for this particular image. So if you want to get a really nice picture with a bony backboard of your cortical landmarks of the posterior malleolus, of the tibia, the talus, and the calcaneus all in one shot, and here's your subtalar joint, that's how you do it. You just lay the transducer towards the Achilles and then refine your skeletal reference points first, and then let's wiggle the big toe. So we're just going to pull the big toe, and you can see that distal musculotendinous junction just pull its way through its own tunnel. There's an osteofibrous tunnel just above the subtalar joint, but here's your subtalar joint posteriorly. Here's the flexor hallucis longus, and I'm just moving the big toe. Again, hallucis means big toe. And that cues us up for the live demo for the medial ankle tendons. Just give me a second while I fire up the studio, and we'll do this live. Okay, so we're back at the medial ankle. We're going to start scanning for the tendons, which is easier than doing the ligaments. But we're working our way from the deep cortical structures in most of musculoskeletal ultrasound, and we're going to work our way more superficially. So I'm going to start on that medial malleolus. Again, screen left is towards the medial malleolus. Very easy landmark to see, and this is definitely something that is easier to see on the 19 megahertz transducer as well. But let's point out the anatomy in this wide field of view that we have. So here's the tibialis posterior, this oval. It's the larger oval. It does have a neighbor here. This is the flexor digitorum longus. Okay, and then they border each other. They pretty much touch each other right there. And then a little bit further back in the image, we can see the neurovascular structures, which we'll focus on here momentarily. But then we see this large muscle mass headed towards the Achilles. So all of this down here is the Kager's fat complex. Here's the Achilles tendon itself. So you see that in the anatomy slides, right? So here's Achilles, here's Kager's, and then here's bordering that is our FHL, or flexor hallucis longus muscle belly, which travels much more distal. And let's follow that until it tapers to a close. So the musculotendinous portion was right here. Don't confuse this far distal muscle belly for a tenosynovitis. For one, we can go long axis on that and see if it moves. So starting on that, let's watch them all move real quick. So in long axis, we'll start on the medial malleolus, and I don't see any tendons here, and then we're going to fall off of the long axis medial malleolus. We're going to fall off of that posteriorly. We're going to keep our probe parallel to the medial malleolus. So the first tendon we encounter superficially up here, this is the tibialis posterior, And distal to the malleolus is when the tendons start going their different directions. We talked a little bit about that in the anterior ankle exam, but the same thing applies for the medial and the lateral exam, is that once we are proximal to the medial malleolus, we really don't have to move our transducer that much. But once we go distal to the medial malleolus, that's when they all start heading their different directions to their insertions. But let's scan this tibialis posterior here. If we wanted to move it, that'd be inversion. Getting the navicular to move, basically. So you can see the tendon on the far right side of the screen tenting up as it is less taut. All right. So now I'm going to fall posterior to the tibialis posterior tendon, just immediately posterior to that. There's another tendon right here. And just to double check our work, that this is the flexor digitorum longus, which we know goes to the digits, I'm just going to wiggle passively the toes. So I'm just going to go start on the second toe, third, fourth, fifth, and just make sure that's the tendon group that we're looking for here. So landmarks underneath that are the tibia, talus, and we start to see a little bit of the shadow of the calcaneus coming into view. Now posterior to that, running parallel, neurovascular structures are going to come into play. That's fine. But let's go find that sustanaculum tali of the calcaneus. So this is your posterior subtalar joint to the calcaneus. And that tells me that we're almost there to see the FHL in motion here. So let's get a long axis FHL, and you can see the joint. Here's your posterior subtalar joint right here, which does in some cases communicate with the tendon sheath of the FHL. So you can have a joint effusion outwardly pour its fluid into this tendon sheath in some cases. So keep that in mind, and let's watch this tendon. I'm going to move the big toe just passively. So flexor hallucis longus. I don't know that I mentioned it in the slides, but hallucis means big toe. Very easy to see it move, but you can see that distal musculotendinous portion try to pull its way down into its own little tunnel. And you just don't want to call that tenosynovitis. You don't want to call it a joint effusion. If you're holding real still and on a lesser quality ultrasound machine, it may appear that this is all fluid and not muscle. See if that fluid moves with the big toe tendon, right? And if that does move with the tendon, then it's probably just the distal musculotendinous portion. All right, so what happens after the malleolar level? Let's go chase those down. I'm going to move all my gel heap around. After the medial malleolus, okay, the tibialis posterior it really looks the most complete here. So we see this very broad tendon take a fan shape grab at the navicular. So it doesn't just attach to the navicular, it envelops the navicular. And here we can see a couple branches of that tendon. The deeper branches are going to go underneath the navicular and head all the way over to the undersurface of the medial most cuneiform. And then these medial fibers, they're going to wrap around kind of like a snake eating an egg around the navicular. So this is navicular, here's the talus, and I can just cause a little bit of motion to that tendon, can loosen the tendon passively and see if any fluid bunches up into those tendinous fibers. But that's one way to do a dynamic exam, is just to lift the navicular with the first metatarsal, basically. So that's a long axis. I'm going to go short axis there, starting at the navicular. So this is all navicular, and here's the undersurface of the navicular, where we catch the majority of that tibialis posterior tendon. So tibialis posterior tendon is this big oval here. This is the undersurface of the navicular. So when I see a big cartilage interface like this, that's talus, and then this is spring ligament right here, and then this is the tibialis posterior tendon in cross section. So just to check our work there, we're just going to creep up towards the medial malleolus in little 1 centimeter increments. We're just going to walk back, forth, and we're going to watch this tendon as it ovals out, and it's resting on top of the ligament complex that we just scanned like a hammock. And we're just going to keep following it, keep following it, keep following it. There we are, back at the medial malleolus. And then its neighbor was the flexor digitorum longus. I apologize, I did flip the probe, bad habit. So we'll go back down just to check our work again and follow it to the, we already did the hard part, right? And that was the ligaments underneath it. So here's the navicular, and then we can see the tibialis posterior here. And you see two ovals here, right here, here and here. One of those is spring ligament, which is over here. And then here was that tibialis posterior. So following that, here we go. All right, and what just came on top of the sustanaculum tali right there? That's not the nerve, that's the flexor digitorum longus, just moving, which is neat because you can also see quadratus plantae down here moving with the tendons because it's just leaving the medial aspect of the calcaneus. Okay, back up to the navicular, medial malleolus. So medial malleolus, flexor digitorum longus, let's focus on that one. Flexor digitorum longus goes on top of that sustanaculum tali. You can use, if you lose it, we can use the anisotropic artifact to our advantage. Right there. So here it is, cut at 90 degrees. Here it is with the anisotropy. We'll go distal and just follow that shadow right here. And this is probably far enough if you're not anticipating pathology distal to the knot of Henry, which we'll talk about right now. So back up to the sustanaculum tali of the calcaneus. So sustanaculum tali right there looks like another medial malleolus. Here's the FHL posteriorly to it. So I'm just going to passively wiggle the big toe and check my work. And we're going to follow that wiggling FHL as it meets up with the FDL, flexor digitorum longus. And here they become neighbors and they're touching right there. And right here where we see the FHL try to pass under the FDL, this landmark, this area right here where it's like if you crossed your fingers, like I'm doing here in the video, that little landmark is called the knot of Henry. And that's another area to look for in abrasive pathology where these two tendons can rub on each other and cause a lot of pain in the arch of the foot. And that's right here. It kind of looks like a yin-yang sign when you cut it at the right angle. So you can see those two tendons, use anisotropic artifact to your advantage. If you want to isolate these two tendons, also just passively move the toes, so little toes, and then the big toe. But that's the knot of Henry. If there's any reason to go distal to that, just keep following each one of those individually. But it's very rare that we need to follow the FHL distally, for example. It's very rare that we need to follow the FDL to its enthesis all the way at the digits. So knot of Henry is typically a spot where we stop scanning for those tendons. But that about covers the tendons. We don't see the tendon sheaths very well unless there's pathology, except for around the tibialis posterior. So I'll switch over to the 19 megahertz transducer and we'll show you the tendon sheath. Of the tibialis posterior. So here's tibialis posterior, bring up my depth, grab my arrow back, much higher resolution. We can actually see the flexor retinaculum, which will be covered in the tarsal tunnel. But flexor retinaculum, tibialis posterior, flexor digitorum longus, neurovascular structures, which we'll chase down later. And then here's the FHL, just posterior to that sustanaculum tali of the calcaneus. I flipped my orientation again. Sorry about that. So tibialis posterior, FDL, and then you can see that really nice FHL. And then let's go look at the tendon sheath of the PTT right there. You can see a normal synovial slip right there, that little anechoic area. And if I grab the big toe and metatarsal and invert the foot a little bit, will typically cause a pooling of fluid around the tibialis posterior if you just wanted to see that tendon sheath. But right there in that corner, that's normal. Don't call it abnormal unless it envelops the tendon. So I would see circumferentially, I would see fluid all the way around the tendon if there was something wrong with it. And then let's just take a look at these ligaments while we're here with the 19 megahertz, since we didn't do that last. So here was that posterior tibio-talar portion. We're going to dorsiflex the foot and look at those ligaments really nice. Very high res. I mean, we're seeing so many fibers, this broad area right here, all the way down to the talus at this point. Now let's move on over to tibial calcaneal. So we need to see that sustenaculum tali, which is here. A little smaller field of view. So seeing the broad ligament all in one shot is not going to happen. So it's really important that you keep a bone in view. So here medially, here's the malleolus, superficial layer, deep layer. You just kind of keep that in your mind. The deep layer is going to the talus, superficial layers for the most part all go into the calcaneus or the tibial spring. And here's that tibial spring complex underneath the PTT. So here's the PTT that we just looked at, the posterior tibialis tendon. And then here's that tibial spring portion just underneath it. All right, so great advantages to using a 19 megahertz transducer, far more detail. The frame rates are actually a little bit more live. So if you're looking at popping, clicking, snapping, this transducer catches those in real time. Very, very nice. And procedurally, it's a lot less transducer in your way when it comes to doing injections around the foot and ankle. So this probe is very nice. Long axis to short axis scanning. As you can see, I'm not having to move very much. For example, to do a long axis and short axis scan of my flexor digitorum longus, it's just moving the fingers and not your whole hand as in a hockey stick. But that takes care of the tendons. We'll go back to the talk, introduce our tarsal tunnel, and then come back to the live scan. All right, so to the tarsal tunnel now. We'll skate through these because all the imaging planes have already been covered, and it's pretty quick to show you the neurovascular structures. So first thing we're going to focus on is this guy, the elephant in the room, the tibial nerve. And the tibial nerve branches off, and it has a medial and lateral calcaneal branch at the level of the tarsal tunnel. Where it bifurcates is pretty variable. So you want to start scanning these pretty high and look for those little bifurcations, or they can get away from you. And then posteriorly, you will see a guy skate over towards the calcaneal neck, and that's the calcaneal branch. Our roadmap for all nerves is going to be arteries. So if you can't find the nerve, come on up more proximally again and look at the artery first as your roadmap. Veins will follow. Chances are if you're scanning anything in this area, you're applying a fair amount of pressure because of that big air gap that shows up when we scan the medial ankle. So your pressure will probably collapse the veins. So be aware that we need to add a significant gel heap here to show that we're not collapsing things like a big joint effusion. Tenosynovitis of the flexor hallucis longus, for example, is very common in the tarsal tunnel as a choking point here. So the veins can be a good marker of how much transducer pressure you're applying. If you're evaluating somebody else's ultrasound images, look and see if you can find patent veins. And if you don't see veins in the shot, chances are they're applying too much probe pressure. Then lastly, we have this flexor retinaculum from the tibia to the calcaneus, and that's our proper tarsal tunnel. But it's all these other factors like the tendons, the joints that can have ganglion cysts, space occupying masses like loose bony fragments can occur in these areas. So if you're not seeing nerve diameter changes, one thing to look for are ossifications in the ankle, old scar tissue that is calcified and clinging itself to the nerve against the flexor hallucis longus tendon, for example, or flexor digitorum rarely. I don't see the nerve branches resting up against flexor digitorum necessarily as much as I do flexor hallucis longus. But right here at that retinaculum is the typical choking point. To get a really nice image of the anatomy, you start more proximal. So you're only going to catch a little bit of retinaculum at first. So if we're up high on the tarsal tunnel at the inlet, we'll see a really nice flexor retinaculum first, but it'll taper off to nothing because we're really obliquely slicing the retinaculum. But it does give us a nice starting point for our tarsal tunnel here. So tibialis posterior, flexor digitorum longus, and now we can talk about the neurovascular structures like the little arteries and the nerves. At this point, it's still laying as one nerve, but I will say that those branches are ready to start splitting. So we'll move the transducer distally into the proper tarsal tunnel, and the anatomy and the landscape and everything starts to change. So it's not just tibia anymore. You're going to see a lot of talus after you leave the tibia and you rest the transducer off the neck of the calcaneus. You're going to see a lot more bony acoustic landmarks be more pronounced right here, like the sustenaculum tali. It's a huge landmark. We need to wiggle the FHL, move the big toe, and show where you are. But this looks a lot like a medial malleolus, and you don't want to call that a medial malleolus because we have a lot more tissue up here. And just to give you some closure on what else is happening over here, we have the superficial deltoid ligament at the sustenaculum tali area. We know at the talus area, this far posterior, these are cross sections most likely of our posterior deep tibio-talar ligament complex. So there's a deep and superficial inserting somewhere over here, but superficial to that, we have a tibial-calcaneal ligament that was the big guy, and then we have the posterior tibialis tendon superficial to that, flexor digitorum longus superficial to the sustenaculum tali of the calcaneus, and that landmark acts as this pivot point for the FHL to wrap around and make this turn with this bony acoustic backboard to provide that leverage that it takes to turn a corner. So it has its own tunnel, and you'll see another little fascial osteofibrous tunnel for the FHL to rest in. And then back here even further, you'll see a muscle that's starting on the medial neck of the calcaneus, which we brushed on briefly on the plantar fascia portion of the last webinar. But that is our quadratus plantae muscle origin on the medial neck of the calcaneus there. All those little soft tissues that are there, we're really just focusing on what's happening with the FHL and the space that is created by this wedge underneath the flexor retinaculum above the FHL and kind of posterior to the sustenaculum tali, the calcaneus. So we're just going to swing the probe from proximal to distal. We're going to wiggle the big toe, so you can see that shadow right up against the neck of that sustenaculum tali, and start moving the big toe. And we'll do that in a live scan. It'll look much like this because it's the same model. And then all this soft tissue out here, this is the muscle we discussed over here, the quadratus plantae, along with the neurovascular structures. Again, I don't have a color Doppler shot on this, but we'll do it in the live study. And then we already went over the soft tissues over here. You can see that now that you know what ligaments look like in the ankle, you know that's not tibialis posterior right here. You know this is tibialis posterior. You know, horizontal acting like a sling underneath that is one of your deltoid ligaments. And so it's nice to have that confidence of what's enveloping the joint before we hit our tendons when you're evaluating the ankle. Let's move over to the live demo. And after the live demo will be our time for live Q&A. So have your questions ready as we do the live demo. Start getting those typed up into the chat portal of the question and answer portal on Zoom. But let's switch over to the live scan and get going. All right, so we'll get back onto the 15 to 4 megahertz transducer into the tarsal tunnel. Screen left would be the malleolar side again. So get my arrow back up here. And let's just start with the easy structures to see, which are the arteries and the veins superficially. We're going to throw on the color and see what that blood flow is doing. If you're not seeing these little veins fill, you're either pressing down too much and you're just seeing an artery. Your color flow settings could not be set for sensitive enough, or you just need to augment the tissue distal to the vein. So you can see I'm just pushing down distal and just working the blood flow up proximally as those veins drain back up towards our heart. And you can do that with the ultrasound. So if you're ever in doubt with the structures that we're scanning, just throw the color on and use it as a roadmap. But as you see me working proximally, this posterior tibial artery will follow the tibial nerve until it branches into 3 parts. So we should see the calcaneal branch kick off first and head posteriorly. And we could see the medial and lateral plantar nerves jump off of it here. So following that distally to the sustenaculum tali, that's where we see the 2 divisions of the nerve for the medial and lateral plantar very nicely. And then we'll switch over to the 19 megahertz and really get a good evaluation on these. But what's nice about the larger field of view is I can see the medial, lateral, and I thought I had the calcaneal portion in here, but I lost it. But we're going to focus on these 2 here at the 19 megahertz exam. So switching over to 19. Back up to the malleolus, and you can see that we're going to get a lot more definition, a lot more nerve detail with the 19 megahertz transducer. I'm going to bring my depth up more shallow. And now let's follow these fascicles and see if there's anything inside the nerves that we notice could be contributing to any issues. So I look for nerve swelling, I look for space occupying masses, calcium deposits, old bony fragments in the tarsal tunnel, but especially here the FHL level where the sustenaculum talli, the calcaneus is with the FHL, this little tunnel here is where we see a big effusion will collect and push into the nerves at this level of the tarsal tunnel. So tarsal tunnel level is defined at the level of the flexor retinaculum, which is this guy superficially. Let's follow it over. So here's flexor digitorum longus, here's the posterior tibial tendon, and then here I can see the flexor retinaculum originate on the medial malleolus, this triangular dark wedge. That's our flexor digitorum longus, or sorry, that's our flexor retinaculum, and we're gonna follow that distally towards the neck of the calcaneus, and just kind of delineate where our tarsal tunnel is. So we can see that little thin line. It helps to move dynamically, but we can see that thin line of the flexor retinaculum. I'm going to keep my finger down on the calcaneus. There we go. So calcaneus, here we are, and here's that flexor retinaculum diving down to just about to the tubercle level of the calcaneus. But just deep to that is our quadratus plantae muscle down here. And you can see these fibers climbing about that level of its origin, I would say. And here we can see the calcaneal branch already starting to kick away, and then we still have the medial and lateral plantar nerves. Let's go down in depth a little bit, turn our gain up a little bit, and keep following the nerves. But that was, I mean, that's the majority of the tarsal tunnel scanning. I'm looking for space occupying masses. I'm looking for FHL, tenosynovitis, ganglion cysts, anything that's going to compress on the nerve as it traverses that narrow entrance to the tarsal tunnel, and making sure that the nerves look uniform, that I don't have any swollen fascicles or schwannomas. Throw the color on if you suspect anything else could be in the area, but that is pretty much the parameters. You can go long axis on this, but there's not a lot of correlation in seeing issues with the nerve and long axis here at this level, because that tunnel's so broad, there's a lot of room for the nerve to move anyways. But long axis can help you correlate a long and short axis for diagnosis. If you're guiding procedures in this area, say to a posterior subtalar joint, which will be covered in a future lecture, it helps to have what's called the color compare tool on. So we can throw our color on and hit either the top bottom here, and we could be doing our procedure from the posterior aspect here, for example. And we could be running a needle underneath the vessels and underneath the underneath all the scary structures into that posterior subtalar joint while simultaneously having color on. So we would see the procedure showing up at the bottom while we're still live. We can still see the artery, we can still see the veins, and not interrupt our procedure with all that flash artifact from a needle. So just one thing to consider when you're doing procedures is all the tools in your toolbox. Color compare is a really good one. You can also go side by side. Side by side cuts off the sides of the transducer to center the image, and I think it can look a little bit confusing, like that's all one image. So top bottom is my favorite. So that does it for the tarsal tunnel. We're not going to take any measurements here because there's no standard. There are some articles out there, but there's no real standard out there that everybody follows, like the carpal tunnel. It's just good to look at the nerves, see what might be occluding them, any space occupying masses, any nerve diameter changes, all those things that we look for in the other nerve entrapment pathologies. But here there's no standard for, you know, how big is the medial calcaneal, or sorry, the medial plantar, how big should the lateral plantar, how big should the calcaneal branch be. There's no standard on that like we have in the carpal tunnel. So it's all relative scanning. Checking with the other side is good practice, but for the most part that's That's it for the tarsal tunnel. I do thank y'all for joining us here today. That does conclude the webinar's recorded portion. We'll move over to a Q&A at this point.
Yeah, absolutely. Like Daniel said, we're taking questions now, so you can go ahead and put those in the Q&A box either at the bottom or the side of your screen there. And yeah, the next final part is on Tuesday, October 11th, and that is using ultrasound to evaluate the lateral ankle. And for information on that and to sign up for that, you can visit our webinars page from the Sonosite website at secure.sonosite.com/behind-the-scan-webinar.
Thanks, Chris. We'll give it just a few seconds and see if those questions come rolling in. Sometimes we get questions, they're not recorded. So just know that your question will not be a part of the recording. So don't feel shy, like you can't ask anything. We're not gonna repeat it on the recording. But
yeah, I don't see anything coming through at the moment.
All right.
Yep. So let me thank you, Daniel, for taking the time to put together this incredible presentation for this webinar. Just a ton of excellent information here. So everybody, thank you so much for joining us. And like I said, Tuesday, October 11th is using ultrasound to evaluate the lateral ankle. And hopefully we'll see you then. Thank you so much for joining.